I'd like to welcome all of you who are joining us for today's discussion. COVID-19 has had a profound impact on our healthcare system, especially for those of you who are joining us today. Based on the HRSA rapid response surveys of federally funded centers, patient visits have dropped by 43% overall compared to before the pandemic. 51% of visits are now virtual or telehealth. Approximately 2,000 health center sites have temporarily closed. Today's discussion will be focused on that path forward for FQHCs and community health centers as you all respond to the COVID-19 pandemic and all the challenges that kind of come with these unprecedented times. My name is Tim Ketterman. I'm the VP of Operations for Adaptive Medical Partners. We're a nationwide medical recruiting and consulting firm, and I get the privilege today of moderating today's discussion with our three guest panelists. Jennifer Genua, did I do that right, Jennifer?
Yes. Hi.
All right, very good. Founder and CEO of Genua Consulting. Jordan Powell, President and CEO of the Illinois Primary Healthcare Association, and Jay Jolly, CEO of La Familia Medical Center in New Mexico. So, hey, I'll start just really easy, throw a softball here by going around the screen and just allowing each of you to tell us a little bit about yourself, kind of where you're calling from, and how things are in your neck of the woods. Jennifer, ladies first. I'll start with you.
Oh, great. Well, good morning, good afternoon. I'm looking at the attendees and I think I know most of you, so I'm going to say hi to everyone. I am in Omaha, Nebraska. I have worked in federally qualified health centers for the past 16 years. 8 of those I've been a CEO and did some interim CEO. And then after my husband passed away, I became a consultant. And so I also am an independent contractor. I work with HRSA, doing operational site visits, technical assistance, and I'm also on faculty with NAC. And I have private clients, and a little bit about me, and thank you to the attendees for all that you do seeing patients.
Absolutely. Thank you, Jennifer. Jordan, you want to bat second here?
Yeah, sure. And first, I'd like to thank you, Tim, and Adaptive Medical Partners for hosting this, really important webinar on, what are the next steps and kind of the future of healthcare post COVID-19. Again, Jordan Powell, President and CEO of the Illinois Primary Healthcare Association. Our organization represents all the community health centers within Illinois, which collectively serve more than 1.4 million patients at 390 delivery sites. So we're one of the larger PCAs in the country, and I've been with IPHCA for about 7 years now, and I absolutely love it. I absolutely love representing health centers. I love the mission. To me, there's no better model of healthcare than the community health center integrated model of care. And I've been CEO of the organization since 2018. Prior to that, I served as the Senior Vice President of Public Policy and Governmental Affairs, so I had that policy and advocacy background. I'm calling today from my office in Springfield, Illinois. We have office locations in Springfield and in Chicago, but while our offices are shut down, I've been coming into the office. It's just easier for me to focus. And, my wife's been working from home too, Tim, and I think she really appreciates that I, get into the office a little bit. So she has her own time. So again, thank you. And I look forward to today's discussion.
Your wife and my wife must be talking because she's pretty happy I'm in the office as well too. So Jay, we'll let you take us home.
Okay, well, thank you also to my co-collaborators here and to Adaptive Medical Partners. I've worked with Scott since about 2007 when he was in a prior situation, but we've had a great relationship over the years. I've been in healthcare for 36 years now. I did about 30 years on the hospital side, primarily rural and critical access organizations in 4 or 5 states. I came down here to Santa Fe, New Mexico 6 years ago to take over La Familia Medical Center, and big shift. It was really interesting because I think the FQHC world has started to see the kind of oversight and regulatory intensity that hospitals started to go through back in the, with TEFRA and DRGs back in the early 80s. So this was, I'm kind of dating myself, aren't I? But really it's been a very interesting transition, and this is a nearly 50-year-old organization in this community. About 18,000 patients per year, 75,000 or so visits. And we have programs in, of course, general medicine, but also behavioral health. We deliver about a third of the babies in Santa Fe County every year. Our physicians do. We have an active dental program. I do a lot of work in substance use disorder, and then we have a healthcare for the homeless program. So we're fairly diversified at about half a dozen sites around the city, and it keeps us all hopping.
Excellent. Jay, appreciate that. You all three have different perspectives that you're sort of different views that you're looking at the FQHC world. And so today's discussion, I want it to be an open discussion, ask questions of each other. The audience, if you guys have questions, we have a monitor who will throw those our way. If we can't get to all of them, we'll make sure we get them answered to you at the end of this. As far as our talking points or our questions go, it's based on feedback from those that signed up, and we took the frequency of the questions that were submitted, and then I had an opportunity to sit down with everybody on this panel last week and try and talk about what their thoughts are and what might be important and might be a value add for everybody who's logged in. So we'll just get started with our first little launching point here. Based on feedback from our audience, actually, the topic that was most referred to was really focused around reopening and what happens next. So we aren't going to start with a fastball here. We're just going to go right at it. So when every decision we make right now affects an organization's financial position, their staff, most importantly, the patients that we're serving, what advice would you guys give community health centers as they start building their strategy over the next few weeks and even months as far as recovering from what COVID has done to the market? Who wants to go first on this one? Who's going to step up? All right, then I'm going to pick Jordan. Jordan, you get to go first on this one.
Great. Thanks, Tim.
Yep.
Appreciate it. I was kidding. Again, Tim, you mentioned that we all have different perspectives. So my perspective is from the PCA lens and a policy background. But my first piece of advice would be, you're not alone and you don't have to go at this alone. Whether it's a PCA, HRSA, the National Association of Community Health Centers, consultants like Jennifer, you have a large number of resources at your fingertips, and really our job is to help you navigate through this time and prepare for the future. And I think that if you try to go at it alone, you're going to have some blind spots. You're likely going to miss something. So if you're also not connecting with your colleagues in your state and other states to share best practices, you're going to be missing out on a lot. Because if you think of all the issues that need to be considered by community health centers right now, both in the short term and the long term, whether it be funding or safety for your patients or your staff, or testing or contact tracing, operations, policies, all of these things, right? Suddenly it becomes really, really overwhelming, and you can't figure it out all on your own. And part of the role at our PCA and what we have done is we take all of that information, we try to put it in a format that makes sense to you. So you don't need to go to 20 different websites. You don't need to go to the CDC or the state health department or NAC or the Bureau. It's all in one place, all in one position. So I would encourage you, if you haven't reached out to your PCA, do that now. If you're not a dues paying member, I still encourage you to reach out. It's really important, and honestly, it's the right thing to do, that we're helping everyone at this time. To me, I don't care if you're paying dues or not. I want to help you get through this time. So in the past, I've had some health centers that say, I was worried about reaching out because I don't pay dues. We don't care about that right now. We care about taking care of you and taking care of communities. So that would be my advice at a high level.
That's great. That's great. Jennifer, do you want to add to that?
I totally agree with you, Jordan. I think PCAs are really important. And if you live in California, I know California has like the regional PCAs as well. So definitely reaching out. And I think we are hearing the phrase, what's the new normal, right? And unfortunately, this is normal. And so it's really looking at, one, we need to protect our staff, because we're looking at, I don't know, Jay or Jordan, like burnout, right? So how do we protect our staff? But not only that, is providing good quality care. So what does that look like for our patients? Because we still have these expectations, right, to fulfill HRSA requirements. And for those on the phone, HRSA has pushed back site visits as of now to October 1. And I would probably check to see if even if we'll have something like that. But I mean, we're still required to fulfill expectations and at the same time be able to provide care and also making sure that we're financially viable. So that's kind of right, looking at what your cash on hand is, especially for temporarily closing sites. So I totally agree with you, Jordan. Coming together and working together is important.
And Jay, how about, so the cash on hand of being an administrator of an actual facility, I mean, that's got to speak a little bit to you as you start making these decisions.
Well, it does. Cash is still king. And so, yeah, and I think there's so many themes that keep recurring every time you look at anything around what we're facing in an uncertain future. And one of those is as Jordan alluded to, the collaboration. I think, communities need to come together. And I think if we just think about ourselves as an individual organization, we really limit our resources and limit our options. And so I think it's a very good opportunity for us to reach out to the community and see find out more about what they're looking for from the health center at this point in time, in addition to what do we need in terms of support from the community. What we've had to look at here in Santa Fe, there's a tremendous amount of community collaboration that is just part of what Santa Fe is about. And so that gave us a good jump on things. But it's a lot of hard work, and everybody has to figure out what their own, what everyone's capabilities are. So in our case, what we did, for example, with testing, big concern about early on not knowing what the contagion would look like was concerns about keeping our staff safe. And it turned out very quickly that the two hospitals here locally were able to set up and deploy large volume testing capacities very quickly. Well, that took a huge concern off our plate. So we did a little testing for the first week or two. Since then, we've been referring everything out to these major testing centers in the community. That's really helped us keep our staff healthy. We've not had a single staff member diagnosed with a positive infection of COVID. So we hope to keep that going. Looking ahead, though, as New Mexico starts to open up, we've been locked down since March 11th, and just opening up now since a week ago. And we're trying to do it very carefully. We have a governor who's very aggressive about the key elements of staying safe, but everyone has to do their part. And so I think for the organization, if we can assume that we're going to still maintain a healthy staff, then we start to look toward how fast we can reopen and look at things like, do we have enough personal protective equipment to keep everyone safe? Our dental clinic lost over 80% of its business because it was restricted to emergency services only, but that's the highest risk program we have. And so we have to make sure that we have plenty of PPE before we ramp up any significant volume there. All those kinds of considerations come into play, and you have to weigh and adapt to what local conditions are.
So PPE is a big topic. I mean, sourcing PPE, I don't care which one of you want to sort of jump on this, but is that getting easier? Are there ways maybe in Illinois that you guys are sort of winning that battle or not? Or is it kind of across the board? Is that still a real pain point for organizations?
I think it's definitely a pain point. And, we've been fortunate at the association because there's so many people that want to help. Our organization has raised $550,000 to purchase PPE. We have it delivered to our warehouse here in Springfield, and then we get it out the door to our members. But it's not nearly enough, and we haven't been able to spend all of the money because the supplies just aren't there. And we're not a supply chain management organization, right? We're doing this because we think it's the right thing to do, and we're not used to vetting suppliers and finding suppliers. And I think that's probably been the most difficult for us, because the last thing that we want to do is order supplies, we get them, and they're not good enough, right? They're not medical grade, or, they're counterfeit. You have a lot of the products, most of the products are coming over from China right now. Many of them are good. Some of them are counterfeit, and we actually had run into that problem. So I'd say it's definitely still a really big pain point for our members.
Is there a reliable source that maybe we could direct some of our listeners to, maybe a national that that you guys are utilizing, or Jay, you're utilizing, or is it really local efforts that are being required?
It's a number of different things. We've got everything from local people making masks for patients that obviously aren't medical grade and dropping them off. And then we have probably at any given time, I would guess we're using a half a dozen different supply sources, and we just have orders constantly going in because the return, it just trickles in. And we've been able to build up our inventory a little bit, but it doesn't happen quickly, and it's quite a bit more expensive than it used to be, of course.
Right. Jennifer, you have anything to add on this, or?
Yeah, I think you definitely want to be careful because we've heard a lot about the N95s and the KN95s. So while the CDC and I think the FDA have said yes, you can use it. The only difference between those two is actually the efficacy and also the length of time that you can use the KN95s. So it's actually the hours, you have to change that a lot quicker. So I think it's really important to be mindful, and the community has been helping. I have a couple of resources that I can send over as well that I know probably Jordan you already have, but just to help out.
Okay.
So right now everything is scarce. We have to remember it's coming from overseas.
Yeah.
And so don't forget it goes through customs, and right now that is kind of being spearheaded to the national stockpile. So that's another reason why as health centers we're not getting a lot of that PPE because it's being diverted. So
Jennifer, I'm actually going to stick with you here because you and I talked last week a little bit and kind of bounce up on sort of those next steps. But for those health centers that are really struggling and perhaps can't see a path moving forward for whatever reason, maybe things were tough going into COVID and this has just perpetuated it, or be it concern over patients not coming back or changes in the local medical community, or even furloughed providers that aren't returning. We're hearing 10-15% of those physicians we're talking to or providers that are furloughed are not going to go back to where they originally were employed. What options do they have? You mentioned some maybe outside the box thinking, but what should those entities be looking to do?
And maybe Jordan, you may think of some too as a PCA. I mean, I've talked to some health centers, and this is kind of confidential discussions as you move forward, right? We have little health centers. What is a merger? What does an acquisition look like? What is merging, coming together to work? And that may be something to start looking at, and also being able to share resources. So if you have a health center, so like Jay, you have special populations funding, correct?
Mm-hmm.
Yeah.
Yes.
So I'm saying, as Jay's health center has this, another health center doesn't, maybe you can work with Jay to divert those, some of those patients. I think also, maybe doing a financial analysis. I hate to say that, but being able to cross-train staff. So with dental clinics being closed, a lot of my clients, we've been able to cross-train staff where they're actually doing some of the MA duties, so to speak, or the front desk duties. So kind of looking at that cross-training. And then you have to look at, cutting costs in this time. I know with the CARES, right, you have all that funding in the CARES Act. There's also a lot of stipulations that we did not know about, right, that they're coming out with regards to segregating that money, making sure that it's separate. So, and making sure that it's for salaries. So I feel like there's a lot of moving parts, but being able to put all that together. And lastly, like I'm a member, I live in Omaha. I'm a patient board member of the Health Center in North Omaha. So we serve about 70% of the patients. We're a testing site for the minorities in North Omaha community. And so as a board, we elected to take a $700,000 loss, in order to keep 158 staff, and that's where you have to come as a board to say, okay, this isn't going to look good. Our A133 is going to be bad with our audit, but you know what? I can sleep at night that I made the right, voted to make that right decision. I don't know, Jordan, have you seen like merger? Have there been some of those types of discussions?
There haven't been those types of discussions here in Illinois. And I mean, I agree with everything you said. There's these difficult decisions that have to be considered and have to be made. I would really encourage those that are listening to make sure that they've exhausted all of the, available support resources, because, some state governments and the federal governments, have made billions of dollars available to keep community health centers afloat. No one wants to see community health centers fail right now. And, I would really encourage, and I know, I'm at the PCA level, and, I hope this doesn't come off the wrong way, but, there's been this temporary time that's been really difficult, but community health centers have existed and have been extremely resilient for more than 50 years. So let's try and not let this, period of time, which I hope does not have, exist for much longer, define, if we exist or we do not exist. As a PCA, we came up with a funding resource document. I think it's a 20 to 25 page document where we outline, every available resource, how you can apply, when are the deadlines. If anyone's listening, feel free to reach out to me directly. I'm happy to share that resource with you. I'll also share in Illinois, we were very fortunate because our legislators appropriated just a few weeks ago, $240 million in new funding to community health centers. $190 million, which will go as direct funding to community health centers, is from the CARES Act funding, so federal funding passed through, and $50 million, which is a permanent rate increase. And if you think about the state of Illinois, which is, if you know anything about the state of Illinois, you know that we're broke and we have no money. And I think that just shows how much, the policymakers and the public really rely on community health centers. So I would make sure that you've exhausted, all of those resources, before making, any type of serious, decisions.
How about there in New Mexico, Jay? Or do you see a lot of reaching out and collaboration amongst facilities, or what's worked there? You guys are in a different climate, obviously a different environment, and it's a very regional problem. Everyone's suffering a bit differently based on local governments.
Well, it is, and we have seen some of that. In New Mexico, we've got 17 FQHCs, but one very large organization that operates statewide. And here, even before COVID started, in the last year or so, a neighboring FQHC to us here in Santa Fe ran into some problems and was looking for assistance, and reached out to several of us, but it was pretty clear that this statewide organization was going to be the one that had the resources and the ability to move in quickly and save healthcare in that community. Mm-hmm. I think coming out of this lockdown period, a key thing to remember as you're looking for the path to the future is focus on the patients, because there's a lot of fear out there. And so one of the best things we can do for our patients and for the rest of the community who may have lost their options that are not health center options, maybe they went to a private office that's closed now, is to let people know, number one, that you are open, and start to get the message out, reassuring the community about your safety practices and keeping people safe, keeping staff and patients safe, doing things to minimize contact. For example, we now don't bring patients who are just coming by to pick up a refill on a prescription. We don't have them come in the building. We deliver it to them in the parking lot. There are a number of things that you can do to keep it safer, and then also get the message out there about, this is the best healthcare you're going to find. So come on out, don't be afraid. We can do it telemedicine. We do screening with the telemedicine calls. If you need to come in, we can do that. But if you can give people options, and if you can make them feel safe and get a comfort level, you're going to build back faster, because they're going to be willing to come, and people are going to go where they feel safe first.
Yeah. Jay, Jay, I got a direct question that came in from Joe, and obviously I'll leave it open to the group here, but with Medicaid as a vital revenue source, how is your health center enrollment team handling or going to handle disenrollments from the last 3 months, as well as newly eligibles seeking care, as it seems retention will be key when full capacity is restored?
Well, retention is key, and I think the part of that is a prior issue. Of course, we have people on the phone calling for on eligibility renewals, things of that nature. We've had a little bit of a unique, well, I don't know how unique it is, but it's probably more here than in some places, because we have a significant immigrant community, and there's a lot of fear about, in fact, we have had people who were already on the Medicaid rolls drop their enrollment because of fears, maybe not about them, but maybe a family member, somebody in the household that they're concerned is going to be traceable, by ICE or something like that. So that's one piece of it that we were fighting with before COVID ever came. It's still a lot of the same thing. Now, we're also doing something a little different here in New Mexico. There's half a dozen of us under the umbrella of the Primary Care Association, and we have formed a partnership that has created a clinically integrated network. So we are contracted on a risk basis with all three of the New Mexico MCOs, and that's so we're managing within that paradigm rather than directly. But we're those the tools that come with that for risk management also help us demonstrate better care, and it's a reminder. You keep going after the things that will keep people healthy. The more contact you have with your patients, the more they're going to remain loyal.
Anyone else want to jump on that? I know it's directed to Jay, but anyone else have input on that question about the Medicaid and the enrollments, disenrollments? All right, Jay, appreciate that. Okay, so I want to jump back just a little bit. So testing was mentioned, and we had a question come in earlier. As our nation works to reopen and efforts are made to kind of kickstart the economy, access to testing is kind of widely accepted as a vital step in that process. What successful approaches are you guys seeing by community health centers that are being used to increase widespread testing? And actually, Jordan, you and I kind of talked a little bit about this last week, I think, in Illinois.
Yeah, so I'm really proud of our testing approach here in Illinois. Our organization actually announced a partnership in April with the governor to expand COVID-19 testing statewide. And when we approached the governor and his team, with the opportunity to expand testing at community health centers, they love the idea. So we were able to quickly work with our members to identify the testing sites and then get them posted online, identify their testing capacity, the testing supplies that they need. And there's definitely, been some hiccups in the road, but we've been able to address those. And in that regard, I think, working with your local and state government is a really solid approach. And you have to go to state government with a solution. You can't always go to them with a problem. So we went to the state and we said, look, we've got this vast network of community health centers with sites all across the state and communities where your constituents are being disproportionately impacted by COVID-19. And, kind of the rest is history. And to date, we have 130 testing sites, 300,000 individuals tested. And, we all hope COVID-19 never happened, but what it's really done for community health centers, it's really elevated the status, if you will, for community health centers. It's made people realize just how valuable community health centers are. And it was kind of funny in Illinois, our state legislature returned to town a couple of weeks ago. Before they came back to the Capitol, they all had to get tested. And guess where they got tested? They got tested at community health centers. So we were really top of mind for them. There's also been a financial benefit, albeit, somewhat small. There is federal reimbursement for testing. Our state is also reimbursing for the specimen collection. I will caution that when you work with governments, sometimes they operate in mysterious ways, and they're all very overwhelmed as well. So we're still trying to address that reimbursement piece. I'm very confident that it will get resolved. And really, our approach has been so successful that we have homeless shelters now. We've got DV facilities that are asking us to work with the state to do mobile testing. So that's kind of the next phase where we're looking at to go mobile.
Excellent. Jennifer, you had mentioned some stuff on reimbursements right before we jumped on here.
Yeah, so similar to Jordan, so in Nebraska, our governor so right now in Nebraska, not only do we not have expanded Medicaid, which we just voted to have it, so it should start in October, but the health centers don't even have a PPS rate for dental. So we're in the middle of getting all this in COVID. And so the governor was a little slow, but same as Jordan, we've been able to become testing sites as well. A lot of my other clients, so I have a health center in North Carolina that actually was one of the FQHCs to receive the rapid COVID-19, the rapid testing. So they could be able to have the test results within 4 hours. So like Jordan, like you were saying, it's really just working figuring out not duplication of service, but being able to work together. So, and I don't know, Jordan, for your health centers. So right now, I think LabCorp, the cost of it is like $52, but reimbursement with Medicaid, I think, is maybe about $60. I don't know, but I didn't know if you're working with your state or Jay, like what does that reimbursement look like?
So for Illinois, and I'll just quickly add, so for those health centers that are getting supplies from the state, the reimbursement's about $30 per test. We do see some successful models where health centers are doing encounters in a drive-through setting. So they're doing a face-to-face visit and then they test the patient. In that instance, they're just going to get reimbursed for the encounter and not the test. We're also, working with national lab partners, Quest and LabCorp. Many of them already have current contracts in place that, cover those costs, and those reimbursements are already outlined in the provisions of their contract. So.
And we're not testing, so we're not seeing any reimbursement for it. Of course, we're referring that out right now. But looking ahead, as part of our reopening, we want to acquire the testing capacity. A rapid test would be what we would need. But we also have a lot of concerns about the reliability. A number of the tests out there, 30% false negative is huge. It gives you very little reassurance. And so we're hoping that they'll come out with both the screening tests and the antibody tests that will give you a lot more confidence that your result is accurate, because we're going to be using that to test our staff regularly, as well as patients. If they're going to have a procedure of some sort in dental, for example, they want to be able to test them, a day or the same day as the procedure, so that nobody picks up an infection between the swab and the result.
Absolutely. So we had another question kind of pop in, and actually this is on a great topic, and maybe shift course here a little bit. But telemedicine, telehealth, it has really been a positive impact with the restrictions lifted here in the short term. And Jennifer, I'm going to direct this to you because it's coming from California, and you have experience in California with your consulting side, and you've just been a little bit of everywhere. But so how are FQHCs preparing for the end of telehealth reimbursement as it's only in place during federal declared emergency? So specifically in California, she says DHCS is likely to stop at once shelter at home in California ends. And then she gave some examples, such as campaigns to come in for school physicals, vaccinations, increasing face-to-face visits. So I'd love to get your input on that, but then everybody, just how much telehealth has impacted, and what's the future look like for that, and what you're hearing, and how big of a role is that going to play? So Jennifer, I'll let you start kind of around the California side, but also share your personal experience.
Yeah, and I'm hoping, I don't know, Jordan, I think PCAs are really big with regards to advocating. And, California has these regional PCAs that they've been working with, and a lot of the California health centers are already part of an ACO or an IPA. So I really think it's important to be able to advocate that. And then data is key. So if you can show, looking at your quality indicators, we've noticed that, yes, there's been a downward shift in looking at those clinical indicators or HEDIS measures, but really being able to show that, we still need to continue telehealth. As Jay said, people are scared to go out, and I think health centers, we were looking at that for healthcare transformation. Last year we've talked about what new age healthcare looked like, but unfortunately in March we were just pushed to do it instantaneously, as opposed to making, within 6 to 8 months. So I have tons of policies, procedures, consent forms, like Jay and Jordan was saying. Don't reinvent the wheel, steal shamelessly. I have all of that. I think it's super important. And I know that some of the payers, the Blue Cross Blue Shield, they're actually paying just like an encounter visit. I think that's super. I love telehealth. What I've seen some other health centers in Northern New York doing is actually choosing a subset of patients. So those mamas that are pregnant, they're actually doing self-monitoring or remote monitoring at home. So a lot of health centers are choosing one chronic condition, let's say it's diabetes, and they're leveraging funding from these funders to give them an A1C, to give them maybe a PT, and give them a blood pressure machine, and that way or a pulsometer, you know, the ones that go on your finger. And that way they're able to collect some of that data. So this is the kind of the type of stuff that we're going to. Obviously there's some things, right, that we can't do from home. I'm really concerned with kids and immunizations. And what I've been seeing is maybe telehealth Monday through Thursday, Friday is kind of child visits. I don't know, Jay, how your scheduling templates look like, but being able to do that. And unfortunately, I think it'll continue to be interesting to see what California does because they have a little bit of a different model. But I think telehealth may be the way to go. I mean, I'll tell you, I used it and I love it, you know, being able to communicate. But the one thing I will say I noticed is that I did not get a consent. So my provider, my MD actually started and I was like, excuse me, you know, like, is there any consent? So it needs to be done probably ahead of time or through Doxy or whatever EHR.
Yes,
Jay?
you know, I think the telemedicine is definitely here to stay, and it's been very successful already for many years in a lot of locations. The last hospital that I served in Kansas before I came down here, we had an active telemedicine program, and Mexico had not used it, had not engaged in it to the same degree, but it's come up in a hurry now with the COVID crisis. But it works, and I think it addresses, as Jennifer alluded to, it addresses the fear factor for a number of people. It also addresses a mobility factor for many times the elderly and others who it's not about the COVID. It's about just it's hard to get around, and so for many things you can see more patients, you can take care of those, you can answer a lot of questions, you can take care of those more basic things that don't require a face-to-face visit, and then your in-clinic time is you know, for needs that have to be handled face-to-face. But it's only going to grow. You know, I think infrastructure in some places, infrastructure is a little bit of an issue in New Mexico, just bandwidth, but I think a lot of places will build that out as they see the benefit of this, because it's just too good a thing to go. Medicare has already said that kind of the cat's out of the bag, and you're not going to be able to go all the way back to where it was before. So now we need to be lobbying for, first we need to demonstrate the value, then we need to lobby for reimbursement that puts it more in parity with you know, with an in-clinic visit. If you're getting the same result and the same benefit, then you should be paid for that. And we have had patients say, well, you know, I didn't even see the doctor. Well, it was in New Mexico, you get paid for a phone visit too, right, under the emergency thing. So yeah, you didn't see the doc, but did he give you any advice, and did you take it? You know, you're still getting the service. So I think that will grow as people learn that you know, there's some real benefit there, but we have to help them understand that.
Yeah, I couldn't agree more with, you know, what was just said by the two previous speakers. And, you know, the cat is out of the bag. And, you know, I'm getting tired of hearing people talk about, you know, telehealth in the short term. Okay. If we can demonstrate that it works, we have the flexibility to provide that kind of care, these things that we've been arguing for, you know, years. The patient outcomes are the same. We have the data to back it up. I think it's going to be really difficult for policymakers and even maybe insurers that don't want to pay for it to roll it back. So I think PCAs, the National Association, have to really take a strong leadership role in this effort. You know, in Illinois, we're not preparing for it to roll back. We're preparing to fight to ensure that it is maintained for the future.
Right now in Illinois, is there any expectation that reimbursement might roll back? I know you say you're going to fight it, but is there a date now, or is it still open-ended there?
Yeah, I believe it's open-ended under an emergency order. When the state legislature, you know, came back, which I alluded to earlier, they were looking at making it permanent at least for another year. It was something that was fought by the health insurance companies, and you know, an agreement wasn't made. But the leaders, the healthcare leaders of our state legislature, had made it clear that they plan on coming back and addressing it. So that's what we're working on right now. But until then, it's under an emergency order.
Yeah. If say we fall when we fall out from underneath the emergency order, and this is really to anyone, but if reimbursements do drop, let's say to 50% of the normal face-to-face encounter, is it sustainable from a revenue perspective? Is there a way to make that still a benefit for organizations? I mean, we don't want that, but should we be planning on both inevitabilities, and is there a model that might work? Because it's a very regional thing. I mean, New Mexico seems, Jay, and you were talking last week, seems to be very open to keeping it, where California, once the emergency order is gone, so this seems to be a very regional challenge depending on where you're located. But in general, are there models that this can be sustainable even at a lower reimbursement rate? Anyone? I don't care.
I also think, I don't know about Jay, because when you look at how providers also bill and code, I'm talking as a clinician. So, you may only have a 15 or 20-minute visit, but if you're also looking at, maybe you had a clinical support staff, maybe you had an RN do some health education, things like that. I think you also need to look at, you may be seeing hypothetically less patients, but when you look at the level, that you're billing based on time and intensity, I don't know, Jay, what your thoughts are. You look at, or the RVUs, you're kind of looking at to see also from a billing perspective what that looks like. Because you're right, like Tim, at the end of the day, we have to remember, we don't want to also skimp on patient quality, right? And making sure those patients get, what are they, they're getting their quantity, their 30 minutes with the doctor, so to speak. But I think that's important. I don't know, Jay, what your thoughts are on that.
Well, I think some of this is, take for example, the Medicare chronic care management benefit is a good example of a recognized benefit that Medicare does pay for. And I think you bill in something like 1 hour increments, and it's cumulative over a period of time, so that the patient may speak with a nurse coordinator, and they may speak with their provider, and they may speak with somebody else, behavioral health specialist of some sort. But that time just gets logged and rolled up, and it creates this record of the ongoing management of some individual's health status, with a chronic condition. And it's actually a very good example, a very good model for how this can work with any number of situations. We're so used to the face-to-face visit that we're not necessarily thinking in terms of the information and the services provided. But take this meeting, for example. A lot of these kinds of things you might have done in a conference at a hotel somewhere. That's going to not happen nearly as often. But we find that, you have to adapt. It's a little different than what we're used to, but it can also be more interactive, and it can be very effective. We can have a conversation. So I think it's kind of a similar set of principles in play as we try to give people a broader set of options, because the business model is really what's changing. And we all know that the face-to-face visit that the baby boomers and maybe whatever the generation after that was, they're still kind of wired into the face-to-face visit. And but the millennials, not so much. They want it on their cell phone. So the model has to change to serve everybody, and that in many cases will mean in different ways we need to take the services out to people. Telemedicine may be the beachhead for that movement, but there's also organizations that I'm sure are already using mobile clinics, and maybe they're used on a more limited basis, and maybe that could be expanded, things of that nature. We just have to kind of think outside of the way we've always done things.
Jay, you had mentioned earlier about the alternating schedule of telehealth through certain days, and then maybe on Friday as those face-to-faces. We got a question that came in for patients who can't be treated or cared for via telehealth in the clinic, such as pregnant mothers, children for vaccinations, well child visits, et cetera. What other strategies have you been successful with, or have you seen have success with?
Well, actually, we don't schedule individual days quite that way. The different providers, depending on what their patient panel looks like, they're scheduled more in line with those preferences. Yes, during this entire lockdown period, when we weren't seeing very many people at all in the clinic, we were seeing the women who were expecting. We saw the We saw some of the SUD patients. There were a few things where that personal contact and that ability to really evaluate the course of a medical condition is critical. And maybe you can do some follow-ups, a mix of follow-ups, but you're going to have to still have your regular check-in visits for over the course of a pregnancy or during the course of a therapy regimen for a substance abuse disorder.
I think that was me that brought that up.
So, was okay. I couldn't remember.
No worries.
Yeah.
But I was thinking, I do agree with Jay. I saw this on Facebook. A health center actually was doing home visits during COVID. I don't know how comfortable I would be as a CEO, to be honest with you, sending my staff in, but I saw home visits for well child visits. I also saw drive-through, and then I can send out, there are these brand new, they're exam rooms in pods that you can set up outside. They're individual. They're made in Nevada. Some of the health centers have been ordering them. I'd be happy to share just like the one page, but so a lot of the health centers have kind of been, just doing something. I think it all depends on where you live and what your community right, wants. Because think about it, that Medicare population, I don't know if I was, older, telehealth would be hard, to be honest with you, but some will adapt. So the other thing I just want to add is that we in our health center, looking at the clinical measures as a board member, we saw that PTSD went up in patients. So we're also seeing some behavioral health clinical measures go up. So I think that's really important to address, that we really look at the health. This has been really scary for people being at home, stay at home, their kids are home, their dogs are barking, domestic abuse violence. I mean, we've seen these increases. So we want to make sure we add those enabling services.
Absolutely.
Just to add a few, Tim, sorry.
No, that's fine.
Illinois, some health centers that have multiple sites, some are designated sites as well sites. And so we're encouraging all the patients to call ahead of time. So, you're coming in for a preventive visit, pregnancy visit, then you're going to go to the well site. You call in and you're having some kind of respiratory condition, you're going to go to one of our designated sick sites, or you might have, morning hours, that's a well visits, afternoon hours that are sick visits, and then you spend that evening cleaning and making sure everything is sterile, then the next morning start your well visits again. So that's what we've seen here in our state.
Okay. Jordan, I'm going to throw just a quick question that popped in and kind of go back to the testing. You mentioned a model where some facilities are actually billing the test as an encounter. The question was, are health centers who are testing providing any other ancillary or enabling service while the patient is present or as a follow-up care? Those facilities.
Yeah, absolutely. And I mean, some of the, examples off the top of my head, translation services, we want to make sure that that's available to patients. Also, we've had, food trucks or, fresh produce trucks to hand out foods to patients. A lot of, our patients are struggling. Even working with the state to have someone there to sign patients up for benefits, unemployment benefits, which is, which has increased quite a bit, not only in our state, but throughout the country. So those are just a few examples that come to mind. But I think, we want to make sure that when patients come to the testing sites, because you don't know maybe when we're going to see them again, to take care of that entire person as much as we can while they're there.
Yeah. Let's change course just a bit. So, when systems, when they operate under extreme pressures for a sustained period of time, they break down, they expose weaknesses. And I would say our health system has been under pressure for, some would say, a pretty long period of time, and some would say exposed right now. The sentiment that we're hearing when we're talking to folks and organizations we partner with is this pandemic could actually change healthcare delivery forever. The new normal that Jennifer mentioned before. Do you guys agree with this statement? And if so, what are some of the biggest changes you see coming that there might actually be a positive for community health centers as we come out the back end of this? So Jennifer, you want to start there?
I think leveraging of funding and funding resources. And right now we're able to have a seat at the table. I think that's huge. Some people don't even know what an FQHC is, especially at the legislative level. So really coming together and have that advocacy. And I think this is a time that we can, pilot something new and be innovative. I think that's really important as well.
Excellent.
So I feel really strongly about these statements, Tim, and I think we might have talked about this last week, that, when I hear, and personally it just annoys me when I hear, these 4 months have changed my life forever, or it's changing everything forever. And I don't necessarily agree with that. I think it's too early to tell. But I mean, I agree with the sentiment that it is going to change things. And what it's really done is, I think someone used the word expose. It exposed the things that we've been arguing about forever: the lack of telehealth reimbursement, the lack of flexibility to provide care, the lack of investment in underserved communities, the lack of investment in community health centers. It's really unfortunate that it took a pandemic for us to say, hey, we told you so. So I think, we're going to see those changes made, and it's going to be beneficial for community health centers, but it's something that we've known, that we knew prior to COVID-19 that needed to be changed. And I think what COVID-19 has done is just press the fast forward button on those things, and they'll be achieved a lot quicker. So there's things that we knew that are already gonna change. As I said before, I don't think there's a better model of care than the health center model of care, the integrated model of care that we know, increases, patient outcomes, it decreases healthcare costs. So why do we really want to change that? Are we going to change everything forever? I really don't think so. I think, again, it's just exposed some of the shortcomings in our system.
Excellent.
Obviously, I feel strongly about this. I'm sorry,
yeah.
I get the question a lot.
That's probably where the question came from. I think you were willing to take a stance last week. Jay?
Yeah, I think I tend to agree with the sentiment of Jordan's comments. Because first of all, healthcare was already changing rapidly in many respects, and I think the pandemic will accelerate some of those changes. I think one thing that I hope it will do and would be outstanding is to get a push behind, not just for FQHCs, but a push behind rebuilding our public health infrastructure overall. That's where our biggest failure, the foundational failure that has put us where we are. We need to fix that. But I think at the same time, well before, and this has been underway for several years, we talk about things like telemedicine that will probably continue to grow and so forth. But I've been much more concerned about the commoditization of healthcare. And, just earlier this year, and it might have been shortly after the pandemic started, Walmart announced some sort of an initiative. I think it might have been with Amazon or somebody, but their goal is to be the largest primary care system in America. Well, that, can that be anything but good? Go into your Walmart and pick a doctor off a shelf. How's that work? And I think when we lose the healthcare mindset, it isn't about numbers of patients seen and just cranking volume all the time, and it has to be done the right way. You have to continue to grow the knowledge base so that the care can get better, so you can maintain more health. All things that are part and parcel of what FQHCs are about. And I don't see more. Some of the technical gadgets that Apple is putting out there, some of them look pretty good, and I think those could be a really nice adjunct to telemedicine possibly. But that isn't, that's a tool. That's not healthcare. And I think we need to really be wary of solutions or new models that really they may shift the dollars from this recipient to that recipient. They may look like they're great and trendy and all the rest, but at the end of the day, are people getting healthier? And that's what we have to demonstrate, is that we're making people healthier and that we're driving down the cost of healthcare, which should be a result of that, not the driver the other way around. So that's kind of how I look at it.
Great, thank you. You want to say anything to add to that? All right.
Yeah, the Walmart initiative is a health center model. I mean, go look at it. It is the health center model. If that tells you anything about how successful our model is. Yeah.
So, so we've actually had people log in from 26 different states, which is pretty exciting. Obviously, the experience patients and even physicians or healthcare administrators have regionally is very different. Everyone experiences it very differently depending on what the community you are. Community health centers primarily care for the most vulnerable patient populations, a large percentage of whom are minorities. So I'd be remiss if I didn't ask, in light of current events surrounding the killing of George Floyd and subsequent protests and kind of what's going on in the world today or in the country, I'm curious to hear your guys' thoughts on what role, if any, you feel community health centers should play as it relates to social and racial inequities in our communities. Who wants to tackle that one first? Jordan, you and I talked about this, so I'll let you go first.
Yeah, well, thank you for asking this question because I think it's really important. And my response is pretty simple that, I believe community health centers must play an active role. And you mentioned, the types of patients that we serve. And you think about the history of community health centers and being born out of the civil rights movement. And I think about health centers that started in Chicago as a way to provide healthcare access to public housing residents. We work every day to address these social, racial, and health inequities. And if you think about, all of us working together, we serve, tens of millions of patients, hundreds of thousands of advocates. And I think earlier on this call, we talked about not, operating as a single, entity, but as a collective voice, that we have a real opportunity to make meaningful change. But, people on the call might have noticed that PCAs have issued press statements. I'm sure a lot of health centers have released press statements, and words are nice, right? Words are comforting, but there must be specific action that's taken, and health center leaders should be held accountable if they're unwilling to take action for their communities. Now, what does that look like? I don't know what that should look like. And I think anyone that says they know what it should look like and they know what the answers should be should take a step back. We really need to listen to our patients. We need to listen to our communities, what their needs are, and then we need to work together and put together an actionable plan and execute it. Because, for me personally and our association, we're not going to sit back and just issue press statements anymore. After what's been occurring in our country for decades, there has to be change, and it needs to come. And again, I think we, are important players in the part to make meaningful change in our country.
Appreciate that, Jordan. Jay, do you want to tackle that next?
Yeah, Jordan nailed that really well. I think that the whole issue of, all of us deal with the fallout from, poverty and lack of education and all of the social determinants of health that we talk about all the time are the foundation to the health problems we deal with. And so we're very familiar with it. And I think part of what maybe occurs is we're used to dealing with it as organizations. We get involved with and establish the programs to try to help with that. But to Jordan's point about advocacy, I think maybe we kind of take it. We know it's there, so we're not taking it for granted, but we're also not maybe making it visible. Sometimes I felt like we get funding, and there's just occasionally I'll feel like there's kind of a sense that, okay, well, we need to make sure that the La Familia is funded so that they'll take care of those things. So we don't want to. I think we don't want to become society's excuse for not dealing with it at a bigger level. I think that's what we need to try and change about our place in this discussion, because it's core to our mission, it's core to our identity, and that's not going to change.
Jennifer, I'll give you the last word. I know we talked last week. This was something you were pretty emphatic about. So,
I have to disclose, I'm a Canadian living in the United States. So this is very, I haven't seen this. My parents told me that in the 1970s, there's this type of movement when the police went on strike in Montreal. So I've never seen this before. So I think it starts with education, and I'm the first to say, I don't know much about it. I haven't seen it. Growing up in Toronto, honestly didn't have this much. So I think education is key, not only for us as leaders to be very vocal, because I'm very vocal about this, but also understanding what systemic change is and what systemic racism is. I mean, yesterday I learned that this type of disparities actually causes physical health issues for women. I mean, that's scary. And so I think it's important that we also educate our staff. make it part of our learning, you know, how we have those clinical competencies. I think it's really important. I posted a link on my LinkedIn about, you know, what really is racism? What does that look like and how we can make a difference? So I think it's, and I agree with you, Jordan and Jay, it's not just saying, yes, we support it, it's actually taking action. And so it's like, what does that look like? And for each of us, it's different.
I really appreciate you guys being candid and sharing your thoughts and experiences. You know, allowing us to, you know, it's a privilege for us to use our platform to be able to get this word out. And hopefully we added value to folks that were tuned in. If you ask questions and they didn't get answered, you know, we'll get answers back to you. We'll get them directed individually to these folks. But, you know, Jordan, Jay, Jennifer, thank you. I know you all are very busy. There's a lot going on, and for carving out time today to share your thoughts and maybe provide a little hope or direction or some at least a feeling of community that we're all dealing with this. I really appreciate you doing that. And you know, for those that have questions, please ask them, and we'll let everyone. I've actually kept something on schedule, which people in my office will say is half the battle with me. So.
Yeah.
Thank you so much for your time. Thank you for being part of this, and you know, we look forward to our continued relationship with you guys moving forward.
Great. Thank you, Tim.
Thank you.
All right. Thank you, guys. Thanks for everyone who tuned in.
Take care.